So it's good to see that we have people from Jordan, from Hungary. Welcome, Nerman, from Iraq. It's good to have you with us. People from so many places joining us. I mean, Adina from Meiring from South Africa, from India, from Peru, from Ireland. You're most welcome. We'll just take a few moments for people to join. From Austria, Malawi, welcome Joan from Bloemfontein, from Ghana. It's really good to have so many people with us from so many different parts of the world. In a minute, we will start. We'll just give a few more minutes from Latvia. Lovely to have you join us. Right. Okay, apologies everyone. We had a little bit of a technical hit right there in the beginning, but hopefully all of us are here. We've got our panel back and we are ready to start. So people will continue joining. We've got quite a few people with us already, but we'll just keep having people join us. So good morning, good afternoon, and good evening, everyone. A warm welcome to today's webinar on children's palliative care. We're delighted that you've been able to join us today. My name is Alex Daniels. I'm responsible for education at the International Children's Palliative Care Network, and I'll be chairing today's session. So this webinar, as you know, is part of an ongoing series on children's palliative care, which we run every third Thursday of every month. It's usually held between 1 and 2:30 UK time, but our times often vary depending on the time zone of the presenters. So thank you to today's presenters for accommodating our time zones. Let's just go to the next one, sorry. So how will our session run today? We've got a slight change in today's format. We have two presenters and I've allowed time for Q&A after each presentation. So you may ask your questions or make your comments either through the Q&A facility or in the chat box. And we want these webinars to be as practical and as helpful as possible. So please feel free to ask questions on the related themes. Just a reminder, you may access recording of this and all previous webinars on our website. For those of you who don't know, ICPCN website is www.icpcn.org. So now it's my privilege to introduce our speakers. And Dr. Michael McNeil is a combined pediatric, hematology, oncology, hospice, and palliative medicine physician at St. Jude's Children's Research Hospital, and he's also the director of St. Jude's Global Palliative Care Program. His clinical and research focus is on defining the current state of palliative care in underserved communities throughout the world and driving improvement interventions to relieve suffering of patients and families facing the challenges of pediatric cancer through culturally sensitive projects in education, implementation, and advocacy. And this research is in conjunction with his clinical time in pediatric oncology and hospice and palliative medicine, implementing evidence-based practices to advance cures and reduce suffering for children with cancer around the world. If that wasn't impressive, he has an incredibly patient wife, and he has 4 active children who he describes as his world. So thank you so much, Dr. Mike, for joining us today. Dr. Cecilia Ogas is a pediatric oncologist at the National Institute of Neoplastic Diseases in Lima in Peru. And she's the coordinator of the Palliative Care Working Committee for WHO's Global Initiative Against Childhood Cancer in Peru. She has a master's degree in medical research and palliative care, and she is the member of the International Society of Pediatric Oncology and the International Association for the Study of Pain. Cecilia is a delegate of Peru in the Latin American Society of Pediatric Oncology. So thank you so much for joining us today, Dr. Cecilia. So just a reminder to please put your questions and comments for Dr. Mike and Dr. Cecilia into the chat or the Q&A. And now it's over to you, Dr. Mike. Are you okay? You want me to share your slides still? You on mute, Mike?
Yeah, it will not let me share my slides.
Okay, so just give me a minute. I'll get your slides up.
No worries.
Okay. Oh.
Oh, now it does. Let me see.
Oh, okay. Sure, because I've got it. But...
Oh, can you all see my screen okay?
Yes, that's it. Yeah.
Beautiful, beautiful,
Great.
beautiful, beautiful. Well, thank you so much for the invitation. Thank you so much for the opportunity to be here. I'm so grateful to share this work. And it's fun to see so many familiar collaborators on this project, on this call today. And so for some of you, this will be familiar because you are actively engaged in this. So, just real quick, the agenda, talking a little bit about procedural pain in children, talk a little bit about our pilot experience, and you'll hear more from Dr. Ugaz with regards to that experience in Peru, and then kind of these next steps and where we're going with the Global Comfort Promise. So first and foremost, pain in children is common, under-recognized, and undertreated. And despite the Declaration of Montreal stating that adequate pain management is a fundamental human right. And for parents, the highest priority after a correct diagnosis is the management of pain, and the greatest distress is inadequate pain management. And we know that undertreated pain has significant long-term consequences for patients, including changes in long-term pain sensitivity, reduced efficacy of analgesic efforts, and especially in the neonatal population, it can have increased morbidity and mortality. In the oncologic population, there's actually some evidence that families consider treatment abandonment because of the repeated painful procedures that their children receive. And so there was a great project, and this all kind of started, this whole idea of the Comfort Promise, from Dr. Stefan Friedrichsdorf at Children's Minnesota, where they just did a survey. They did an audit of the hospital, where one day they walked through the entire hospital and they just asked their patients, are you in pain? And if so, what was causing your pain? And how would they rate their pain? And what were the things that relieved their pain? And they came away with some pretty profound findings. First and foremost, the most common cause of pain and anxiety were actually needle pokes. Not surgeries, not trauma, but that the most common cause of their anxiety and distress when it comes to pain was needles. And that there was a big discrepancy between what they found in the chart as far as what was being recorded by the staff and what these patients were reporting. And so here's the kind of the table showing that needle pokes were the #1 source of discomfort. And here is the chart demonstrating that, as you can see, almost over a third of the chart said no pain, while only 3.6% of the patients said that they had no pain, while almost half of the patients said that they had pain of 7 to 10, while only 14% of the charts showed that. So a big discrepancy between what we're recording and what is actually being reported by the patients in real time. The other thing that was really interesting that they identified was the fact that analgesic medications and pharmacologic interventions were not the most common cause or the most helpful strategy in addressing this pain. That patient participation, as well as caregiver participation, swaddling, infant comfort, distraction, and positioning, these non-pharmacologic interventions were actually very helpful in addressing these pains, especially with regards to these needle poke procedures. initially one of the thoughts is, could this just be related to the population that they were studying in Children's Minnesota? And they actually identified very similar findings in Pietermaritzburg, South Africa. The most common causes of pain in this institution in South Africa were also needle pokes. There's a big discrepancy between what was recorded and what the patients were reporting, and that non-pharmacologic interventions were quite helpful in addressing that pain. So what Dr. Friedrichsdorf and team did at Children's Minnesota was created this quality improvement intervention known as the Children's Comfort Promise, where they looked at what are the challenges that we're facing to address the suboptimal patient experience with pain and anxiety, and thinking about what were the things that needed to be done from a staffing and process. What do they need to do from education of both the staff as well as the families? What are the attitudes that we needed, and really building out that environment to ensure high quality management of this painful experience. And so they actually created a quality improvement bundle, including 4 steps: topical anesthetics or numbing cream, positioning techniques that were not holding the child down or forcing them, but swaddling or cuddling with the child, distraction techniques, and then topical sucrose or breastfeeding for infants less than 12 months. And they implemented this quality improvement intervention throughout the hospital over a period of time. And you can see, for example, here in the neonatal intensive care unit, that over a period of time, they were able to get 100% bundle compliance. And that was kind of their motto, was every child everywhere, right? That no child should be experiencing pain with this experience. And really, they were quite successful at this large multi-institutional, multi-center institution. And so really this helps us understand kind of this principle of quality improvement. And the whole idea of quality improvement is to mind the gap, right? That we know in medicine, we know in what we do, that there's a difference between what we know, right? The knowledge that we have of evidence-based medicine and our practice. And so quality improvement tries to address that by really help us go from dissemination of knowledge to the implementation. And there's good literature that show that this process, from production of knowledge all the way to general practice, can take upwards of 17 years. And so that's where quality improvement comes in to try and address that. And so our question that we really wanted to try and answer was, is this Comfort Promise bundle that has been developed and demonstrated in Children's Minnesota and now at other places in high income contexts, could we implement this in resource constrained settings, knowing that there are minimal resources that are needed to be able to do this? And so we used a quality improvement methodology known as the model for improvement to really think about that, to understand what are we trying to accomplish, how do we know that a change is an improvement, and what are the changes that we're going to make, and using PDSA cycles to assess that. We also use Deming's theory of profound knowledge and understanding and appreciating the system and human behavior, right? One of my favorite quotes is the idea that any sort of quality improvement intervention is 20% logistics and 80% human to human connection, right? That really the key to all of this is how do we connect and interact with other individuals in creating this system and creating this buy-in and support from the system. And so our goal in this global comfort promise was to really, most importantly, benefit the patients and the caregivers, address this anxiety and stress, but also learn, generate experience, understand how and what successful implementation looks like, and then be able to provide guidance on how to measure this and think about how to do this in diverse settings. Now, just real quick, just a pause, and I'm going through this very quickly, and I apologize, but so please feel free to type things in the chat as we kind of walk through. But I want to pause and think about why quality improvement for palliative care, right? And when we think about palliative care, the definition from the WHO in 2018 is that palliative care is the prevention and relief of suffering. And so when we think about quality improvement, we think about often we're addressing the disease-related suffering of our patients, the treatment-related suffering, especially in pediatric oncology, where our chemotherapies, our radiation treatments, our surgical interventions, all can cause quite significant treatment-related suffering. But then there's also systems-related suffering, right? Inefficiencies in the system, inefficiencies in what we do, and that causes significant suffering as well. And so quality improvement addresses that system-related suffering. So just as we learn about the disease-related suffering and the treatment-related suffering and how to prevent and relieve that, I see quality improvement as another opportunity for us to really address the suffering that our patients experience by addressing that systems-related suffering. So what we did is we created a pilot. We wanted to see if we could test this in the feasibility of implementing the comfort promise in diverse settings, as mentioned. And so we created this global comfort promise, and we piloted it in 4 countries around the world. You'll hear from Dr. Ugas from Peru, but then also had a team in Barretos, Brazil, in South Africa, and in the Philippines, really trying to get this global scope and understanding of could this be done in varied settings, culturally as well as contextually. And so in the beginning, we did a workshop. It was a several-week workshop. This was peak COVID, so it was done virtually, where we sat together and we answered some of these questions from the model of improvement and really thinking about what are we trying to accomplish? How will we know that a change is an improvement? What are those changes that we will to make an improvement? And then really thinking about how do we create a package that is faithful across systems so that what can be done in Peru can be compared to what's done in South Africa, but also adaptive, right? How can we create something that has unique elements from Brazil that can also be done in that might be unique from what is needed in the Philippines? With that, we also created a SMART aim. We created kind of what was our overall aim that we were trying to accomplish for the sites as a whole, but then each site was able to create their own specific aim of how they wanted to address and alleviate that pain. Additionally, we created outcome, process, and balance measures. What are those key outcomes that we wanted to really get from this experience? And what are those process measures that we wanted to follow to ensure that those outcomes are achieved? And then finally, some balance measures. How do we know that this is working, but this isn't impacting other parts of the system, right? That by implementing this, it's impacting other needs of the system. And so we created this driver diagram, thinking about what are those primary factors that will help us achieve our aim in clinical engagement and staffing, education of the workforce, creating a process, having access to these materials, and then engaging with the patients and parents. And then thinking about what are those secondary drivers that impact those primary elements. And then some specific change ideas that were created by these different sites to really achieve that overall aim of increasing the utilization and reducing pain. In order to do that, we created some forms, right? Data collection forms to really see what the experience was. And as we think about quality improvement, right, we wanted to keep these as simple as possible. So the top left is for the actual provider performing the needle stick procedure. This bottom left is for the family, right? Just a few quick questions of what their experience was like. And then we had a third form that really looked at, kind of an external observer, an auditor who could kind of walk through and see how things were going and interview a few families and get some feedback about their overall experience. And so just real quickly, I would love to share just kind of some of the experiences that we've had while leaving plenty of space for Dr. Ugas to share about her experience in Peru, excuse me. But from the team in Brazil, we saw that they really wanted to create this culture of comfort, right? That they had signs all throughout the hospital describing that this was a hospital sem dor, right? A hospital without pain. And so really providing education to both the staff as well as to the patients and parents that, the expectation is that there is no pain during these needle-based procedures, and that wasn't something that was taken lightly. They also created these comfort corners where every unit of the hospital had some distraction toys. They had the lights for younger children, the toys for the older children, and also kind of a box with the topical anesthetic. So every unit of the hospital, the access to the supplies was right there. They also created their own diagrams and fishbone diagrams to understand the processes and the needs and addressing each one. And they even got the clowns involved, where the clowns created this song to really, share the and walk through the hospital and kind of come up with this creative song. And so there's a local and famous song in Brazil that they adapted and kind of a parody to kind of really come up with this idea of homogia sem dor, right? Or where it's with the little cream, there's no pain. And so we'll see if this works. Sometimes the sound doesn't work. Can you guys hear that?
No, we can't.
You can't hear it. Okay.
No.
Let me see. Let's see. I may have to stop sharing and go from there. But what you can see is they kind of come up with this, and I'll share this with you guys after. But they have a whole song and dance that they do, where where they kind of walk through the hospital and they sing this song to all of the patients, and so all of the patients and all of the families know this song. And so, I had the chance of visiting Brazil, and it really was all of the patients have this dance memorized, they have the song memorized, and they know that it's there, right? And so you can see everybody in the hospital, all of the families, all of the patients, all the staff, they know the song. So I'll share this with you guys afterwards, because it was just really fun to kind of see how this is something that doesn't have to be kind of very, I don't know what the right word is, uh, bland, right? The creativity is there to really come up with these novel ways of addressing this, and educating the staff, right? Not just a sit down opportunity but to kind of have these workshops and things, but that you can create these creative ways of sharing this information and educating the staff. And this song was one of the ways that they did that for the patients and families. In the team in the Philippines, right? They were able to see that as they looked through their processes, that they were actually poking the patients twice, that they were doing multiple needle stick procedures every time a patient would come in. And that they had patients and families that actually were considering or had abandoned treatment because of the distress that came with these needle-based procedures. And so they revamped their processes to ensure that the patients were comfortable, and that they would ask for this magic lotion throughout the institution, and that the patients had these things. And in fact, they actually named their process after patients. So Liam was one of these patients that actually was going to abandon treatment before they treated the system. And so in Tagalog or Filipino, this acronym means always thinking about pain. And so just another opportunity for us to really think about, how do you create the system and where you get patient and parent engagement and buy-in and support, and be able to use these different techniques in support of both the patients and families. And then in South Africa and Pietermaritzburg, they were really able to kind of learn and see these principles. And it was very different because their staff, it was the registrars that were doing this. And so every month there would be new registrars. And so how do you then educate and build these, and ensure that the staff is there to be able to understand how to address this? And they saw a significant reduction in the pain of their patients. But what I love about this is we actually interviewed some of the staff, and to be able to hear these registrars, these young physicians, talk about how powerful it was to focus on these things, right? Within the busyness of all of your education, they realized that at the end, this reminds us that our goal is to be kind and compassionate, that we sometimes lose sight that this present moment for each child can have such a huge impact on their treatment. And so just the understanding again that while we're doing this and focusing on the simple quality improvement initiative that's addressing these things, that it is a friendly reminder that we need to be kind and compassionate and caring. The other thing that I loved about this experience is, for all of this, as we were kind of building this project, to see that for many of these sites, the idea of the distraction techniques, the positioning techniques, not a problem, right? And then the breastfeeding and sucrose, we actually expanded it to patients up to 24 months, knowing that in many cultures, breastfeeding is common up to 2 years of age. But the topical anesthesia was a real sticking point, and the fact that, hey, we just don't have this in our country, we don't have this in our hospital, it's very expensive. However, through this project, we were able to get all of our sites to have these new topical anesthesia, and we see here that the high satisfaction rate. All 4 of the sites, we saw very high satisfaction rates, and from our patients and parents, and reduction in pain. The pain went from about 60% to less than 30%. At these 4 sites. As mentioned, we saw that there was adherence to at least 2 of these comfort promise principles. And now that all the sites have consistent access to topical anesthesia, we're working to ensure that all of the elements of the comfort promise principles are consistently applied across all 4 of those sites. And what I really love as well, and we heard this from some of the quotes from the staff, was that there was actually really high satisfaction as well from the healthcare providers, right? That they were seeing the impact that this provided on their patients, and that it didn't reduce or it didn't prolong the intervention times, it didn't prolong waiting times. In fact, it reduced them, and that they felt more satisfied with what they were doing. And so oftentimes when you do quality improvement projects, there's that fear of, oh, you're giving me another task to do, you're giving me more work to do, um, and I can't do that. But really seeing that by implementing this comfort promise strategies, it actually resulted in making their job easier, because the patient wasn't screaming, wasn't crying, wasn't thrashing their arms everywhere. It created a calm environment for the patient, the parent, and for the staff themselves. And so we were really encouraged by these results, and I'm excited for you to hear about Ceci's experience in Peru and some of the innovative ways and in specific ways they were implemented in Lima. And so, but as I mentioned, where are we now with these 4 sites? We really want, and we're here as far as this expansion. And so with all of these sites, we're seeing that, now we're working to build a sustainable and scalable model, and sustainable as far as getting all of those comfort promise interventions to be consistently applied, and then expand to other patient populations, knowing that children with cancer aren't the only ones that have these needle-based needs, right? We started there because of the understanding of the number of needle sticks that these patients require for their treatment, and knowing that there are other populations that also have high needle stick burdens. And so how can we expand to other units of the hospital, and other parts of the hospital? And Ceci will kind of describe some of that, where they started in one area of the hospital and then learned that there were other areas that really need it. And now patients are familiar with this process and are asking about it in other areas of the hospital. The other thing that we're very excited about, and some of you are a part of this, is the realization that we want to be able, now that we've been able to pilot this and see feasibility, we really want to better understand global dissemination, really understand how do we implement this in a truly global context. And so we have a strategic partnership with the Institute for Healthcare Improvement, which is a large quality improvement organization that works around the world in building quality improvement collaboratives. And so we're doing an improvement in science and action course where we've expanded to new sites where they get a longitudinal quality improvement training as they're implementing the Global Comfort Promise package. We've also added another step, right? We've seen, as I mentioned, that we have already expanded breastfeeding to infants up to 24 months. And we realized that for those over 24 months, a lot of the sites were actually using praise and a reward as well as a way of supporting patients. And so we added that as a step for those that are over 24 months. And so we just started this. We're really excited. We actually just finished the pre-implementation phase and just had our first and second course where these sites are all gathering their baseline data before implementing the Comfort Promise. What is their current state of pain that their patients are experiencing? Really identifying the problem, doing process mapping, seeing where are these opportunities to implement change ideas. And in the coming months, really kind of start thinking about the theory of change and start implementing the Global Comfort Promise throughout their institutions. And we actually have 24 institutions from 19 countries around the world. Several of you are here today. It's great seeing you. And it really, as I mentioned, we wanted this to be a truly global project, right? Not just in one region, not just in one country, but really have projects in all 24 or in all WHO regions around the world to ensure an understanding of what are those culturally and contextually unique factors that require adaptation, and what are those things that are consistent across the board, no matter where you are in the world, and how to be able to implement this successfully. And really, the goal of this project is to ensure that children have a simple evidence-based approach for addressing needle-based procedural pain and understand how this intervention can be implemented around the world. Huge thank you. This is there's an incredible amount of people who've been involved in this project, and I'm so beyond thrilled to continue to do this and just to have the support that we have from all of the folks. And a special thanks to Dr. Friedrichsdorf, who really began this idea that no child should experience pain, and that we should have these pain-free institutions around the world. And so thank you for the time, and I'll stop sharing and just answer questions real quick, and then be able to pass it off to Dr. Ugas.
Thank you, Mike. Thanks so much for that. That was great. I wonder, it's just really great to see, we saw that map last year, a year ago, of people participating, your participating sites. And it's just wonderful to see how that is actually expanded. 24 institutions, 19 countries. That's really impressive. But I think that while we're waiting for questions and comments from people, I wondered if we could just maybe hear from Dr. Cecilia if she has any comment on your presentation, what you've offered, and based on her experience, just what she would like to, if there's anything she'd like to share. But before we hear from her, I also just really wanted to acknowledge that I think, you have your own way of measuring, but from the outside, what really impresses me about this project is the commitment to engaging with those initial 4 sites and really get a sense of what were the particular challenges within those sites. And so trying to create a product, if you like, that was culturally appropriate, that was very unique to that particular site. And an outcome that all sites report more than 90% of patients and parents being satisfied with a real-time needle stick injury, and a 30% reduction in pain is quite an achievement. And I think what's also really great to see is to hear you say, is to talk about expanding this beyond the oncology sector, because many of us know that if we ever walk through a busy outpatients building, a pediatric outpatient, we can sometimes hear those distress signals. So, sorry, my video keeps disappearing. But we can hear those distress signals, and nobody wants to do a job. We all want to do a job that's easier. So if this impacts on our experience as healthcare professionals and makes our job easier, I mean, why not? But I just wondered whether you've had in any of those 4 sites, whether you've encountered resistance from healthcare workers at all. Have you had that experience at all?
Yeah, so great question, and I'll definitely leave the opportunity for Ceci to kind of talk about some of that. Definitely, needing buy-in from the staff, right? You cannot do this without the staff buy-in, and so I know Ceci's had some experience working with the nurses and really kind of getting their engagement and buy-in, and having some champions really support that. But yes, there's always kind of resistance anytime you implement something new and it seems like extra work. And it's really kind of slowly helping them understand the impact, showing the data from Minnesota, showing the data from these other experiences, and being able to go from there. And over time, as they see the success, as they see the impact, then it really kind of starts to spread, and you have that positive spread. The other opportunity, and I think what's really important that you bring up, the cultural context, and really making sure that opportunity for adaptation is key, and also learning from one another, right? I think one of my favorite parts about this project is we meet about once a month, all 4 of the sites together, to kind of talk about how things are going. And what was so cool for me is not for us here in Memphis to say, hey, these are the things that you should do and this and that, but for the team in Brazil to say, hey, we're having this challenge, and we're thinking about doing a workshop, and kind of what have you guys experienced? And the team in the Philippines to say, hey, we had the exact same problem, and this is what we did to solve it. And so it was the four sites coming together to learn from each other, right? And really being able to share their experiences and learn from that I think was really essential for this. And that's what I'm excited about for some of with the newer sites as well, as we continue to expand, is really see how each site can be creative and learn from one another, and that it's more of creating a space for this opportunity to share their experiences and be able to grow. I do see a question in the chat with regards to new institutions joining. We are excited about this. This current group that we're doing, this current cohort, is a part of a very specific kind of initiative and collaborative that will be going through the next year. And we're hoping that once we're able to kind of really understand and study what are those key factors that result in successful implementation, our plan is to continue to expand in the coming year or two. And so please feel free to reach out and touch base, because we would love to kind of share our experience and be able to learn more.
We have a question and a comment from Joan Marston. She says, Stefan has been such a good mentor. She wants to know, are you teaching the magic glove? And she raises, very good question. But she also raises a really important issue around resources, and that at present in the province that she lives in, in many places in South Africa, and no doubt in other parts of the world, basic medication are not available for state patients. So getting EMLA or another topical anesthetic is very rare. I wondered if you could comment on that.
So we do, kind of, if their topical anesthetic isn't available, we do work and kind of talk with folks about using things like the magic glove. The other thing is using an ice pack, right? Kind of or a cold pack or something like that for a few minutes on the site. That can help numb things a little bit, make it a little bit easier. And what we saw is, again, as I mentioned, of the sites that participated in the pilot, the topical anesthetic was definitely one of the things that everyone said, hey, I don't know if we're going to be able to get access to. And with the advocacy work of the site leaders and being able to work with the institutional leadership, all of them were able to obtain topical anesthesia. Some is through private donation. Some of it has been through kind of working with pharmacy and adding it to their formulary. And some of it is actually kind of being able to make it on their own, that there are kind of recipes to be able to use lidocaine that is being used for procedures, and mixing it with a little bit of cream and kind of creating your own. And so very cost-effective ways of doing that. And so I think absolutely we have the opportunity to use other interventions beyond topical anesthetics if it's not available. And one of the things that we encourage folks to do is to advocate for it, knowing that it is effective, knowing that it works, and seeing that there are creative ways to be able to get it, and being able to support them in that space.
Would you tell us, for those of us who don't know, just a little bit about the magic glove?
Yeah, so the magic glove is a really fun and kind of a powerful kind of psychological tool that is used, where using kind of touch and being able to kind of put on this glove, you slowly move and touch the fingers and touch the patient to put on this magic glove. And it's a powerful demonstration of mind over matter, right? The mind over the body, where as you push this magic glove on and you put it on and you squeeze the different spots, it actually, reduces the nociception of that location, and then you slowly remove it. And it is a really cool, very fun kind of experience. And when Stefan did it on me, I was like, there's no way, it's not going to change how I feel. I'm still going to feel the needle poke just as much. And it was very powerful to kind of see that the power of touch, the power of kind of this opportunity to kind of use that. And so certainly if there's interest in that, there's some good resources and videos online to kind of learn that.
Great. So we know that you're going to have to leave, Dr. Mike, in about 15 minutes. So hopefully you'll be around for a little bit of Dr. Cecilia's talk. But just for those people who are expressing an interest in making contact, like Anina Meyring from Pietersburg Polokwane Hospital in South Africa, and also Veronique from Mumbai, India, the Indian Pediatric Hematology Oncology. Maybe just to say we will have this video up right at the end, probably not today, but in the next few days we'll have it up on the ICPCN website, and we will also have your details. Would that be all right? And they could make direct contact?
Yes, please. Love to chat more, love to kind of express more. Even if not a part of this cohort, we are more than willing to provide the materials that we've developed for the groups and be able to support anyone who might be interested in these things.
Okay. All right.
All right.
So I wondered if Dr. Cecilia had a question for you before you disappeared. Were there any specific comments? I think you're on mute, Ceci.
Oh, sorry. No, I'm very happy to be here and to be a part of the Comfort Promise. So I don't have comment. I think can I share my slide now? Yes. Oh, I can hear you.
Please go ahead.
Okay. Give me a moment, please. Okay, here. Okay. Now you can see my screen?
Yes, we can. Just a moment before you start, Cecilia, just to say, just in case you slide out and we don't say thank you, Dr. Mike. Thank you so much for joining us today and for an incredible initiative. We all know the importance of dealing with pediatric and procedural pain. You know, Dr. Stefan likes to say that when children with unrelieved pain they turn into adults with higher rates of chronic pain, anxiety, and depression. It's more reason for us to pay attention. So thank you so much for joining us today and for your contribution. And may the Global Comfort Promise go from strength to strength. Thank you.
It has been an honor being here. I'll stick on for just a sec.
Okay, cool. Dr. Cecilia, we ready? You can see your slides, and I hope you're able to move it.
Okay. Hello, everyone. I want to thank the organizer for the invitation. Being part of the Global Comfort Promise has been a great, super enriching experience that has allowed us to reduce the pain caused by needle stick in our little patients. Okay, nothing to disclose. And first, I want to show you where my country is. Peru is in blue. It's located in South America, and we are considered an upper middle income country. And in addition, I want to show you the diversity of my country. Have 3 very marked areas and cultures, which is very important when educating the patient and their family. First of all, we have the jungle in green, where some tribes such as the Boras still exist. Then we see the mountains in brown. Here you can see a photo of Machu Picchu that is very, very nice. And finally, the coast in yellow. In the center is Lima, the capital, and this is where I live. And now this is my hospital. One of the main characteristics is that we are the National Reference Center for Childhood Cancer. So we serve approximately 70% of children with cancer in the entire country. The rest is distributed between social security and private. It consists in 2 towers. The first is the hospitalization area, where our patients are in the 5th and 7th floor. And the second tower is new and is for outpatient management, where we do consultation, chemotherapy, and special procedures, including marrow aspirate and lumbar puncture. So we have 78 hospital beds distributed between the 7th floor, 5th floor, transplant, and emergency area. In the outpatient area, we perform 15 to 20 procedures daily and 50 chemotherapies daily. And we handle approximately 850 new patients per year. And the distribution for nurse is 1 nurse for every 6 or 8 patients. And as Mike already mentioned, we are one of the 4 centers where the Comfort Promise pilot began. Based of Dr. Stefan's student and those carried out in South Africa, we also managed to demonstrate that in our hospital, 32% of our hospitalized children have intense pain due to the use of needle, and this was the basis for our authorities to become interested in this project. So it was very, very important our study. And the percent is the same for the other countries. No? And this is how we embarked on the Comfort Promise project. The beginning, our timeline is starting in April 2021 with the invitation to participate in the project. Then came the Quality Improve workshop. This was the first, and then subsequently in November 2021, we already have the meeting with nurse director and heads of pediatric. And then the training of nursing staff and nurses techniques, and especially in the 5th hospitalization room or floor, because it's in this part that we began the pilot in July 2022. And then we changed, no? And integrate other part in October 2022, began in the area of the special outpatient procedures. And one of the important things was to prepare the material because the data collection forms were in English. We need to do the translation into Spanish to make it easier for health personnel to fill out. The majority of our nursing staff doesn't speak English, so we need to put that in Spanish. Then through the fishbone, we were able to establish the key points where we could act, such as managing and obtain the topical anesthetic, preparing educational material, speaking with the authorities so that they could assign us personnel and provide us with a protect time. And remember that we were in COVID times, so at the first, the training was done virtually, and our pilot begins in the hospital area in the 50th floor, which has 15 beds. Here is one of the photos of the training for the nursing staff and technical staff, in addition to delivery of daily use materials such as pain scale according to the age and dosages for pain managed in children. And we have a virtual reality equipment that was donated to us pre-pandemic, and that wasn't being used. So arrangements were made for it to include that in the project, so we could use it. Here in the picture, we can see the delivery and training in the use of virtual reality for nurses, staff, and training in use with patients. No? We have 10 virtual reality devices with special integrated software where when the child is going to be pricked, a button on the remote control is pressed, a new imaging appears so that the child is more distracted. No? We can see the delivery of the material for the nurses staff. And this is the summary of the year 2022. And as you can see in the graph for July to September, there were few cases that corresponded for the 5th floor hospitalization area where the pilot began. So at the moment, we asked ourselves why so few patients. One of the reasons is that the majority of our hospitalized patients come with central venous access from emerging. So they didn't require the use of the peripheral line. So we've reformulated our strategies and decided to start in the area of the special outpatient. procedures, where average of 15 to 20 procedures are performed daily. In this way, you can see the change and more patients enter the project base. Here we see some pictures of the comfort in special outpatient procedures, but we continue to have difficulty in making it sustainable, especially due to lack of the personnel or frequent staff turnover. No? So this is our challenge. No? And I have a lot of challenge. No? We see this challenge every day. So the first, definitely one of the main challenges, especially at the beginning of the project, was the COVID pandemic. Because, for example, we couldn't use the virtual reality masks, access to the hospital rooms was very, very limited. Fortunately, this has been solved over time, and now you can enter the different volunteer groups, for example, no warehouse. No? Then we have the heart nuisance, which again delays the war already done. No? Happily, this year, a permanent head came in for at least 4 years, and that already gives us more stability. We still continue to suffer from the constant rotation of nurses assistants, so which forces us to increase the number of the training sessions, because they change at months. No? So we need to more training and help there. No? Political instability also play a fundamental role in the last 3 years. We have had 5 presidents, and we have suffered a coup d'etat. What does this affect us? Because what happens is that with each change of government, all the hospital authorities change from the director to the heads of the service. And well, that we have to explain the project again and convince them to give us a little time protected to train staff, or for example, to fill the database. No? Maintain the interest of the health person in the project is important too. Happily, with constant training and certain incentive, such as worker of the month or surprise prize, we have managed to maintain interest in the project, no? for nurse or all the health person. Get the topical anesthetic with although we don't have EMLA, no EMLA brand as such, but we have been able to send the product with the same specifications, and the support of some foundation has allowed us to always have the product on hand. No? We received the donation for that. Under staff and overloaded nursing work, one of the resources that we have used in our favor this year was to incorporate the group of volunteers from the hospital. Really, with their support, the project is become sustainable, because the nurses feel that they have help, especially in the passing the data. They are volunteers who work with an assigned day, and if the volunteer team is missing, for example, they assign another person for that day. And maybe protect time is very, very important too. I think it's one of the biggest problems, because most of the time we don't do every single side of our work hours. No? So I believe that these challenges maybe is the same for other countries, but it's important to create strategies to improve that. This is our update goal now: the prevent or alleviate pain in more than 70% of needle stick performing in children with cancer by applying the principles of the comfort promise at 5 St. Global Partner Institution in the first 6 months of implementation the procedure outpatient rooms. And now we see that the arrival of the volunteer team become more sustainable, managing to admit many more patients. No? When you see that part, when have only a few data, is because all politician problem in my country. And here you can see how use the virtual reality to reduce the pollution. This is our climate. The patient is distracted, and here's the nurse.
Yeah.
And this is when patient receives asparginase.
¿Qué estás viendo? ¿Muñecos? ¿Disparando? A nosotros también nos deben hacer la terapia de relajación. Yoga nos deben hacer, perdón que respire. Tú concéntrate en el juego, ¿ya, yo, Navis? Muy bien. Concéntrate, ahí van a aparecer unas figuras. A la cuenta de 3 aparecen unas figuras. 1, 2 y 3. Ya está.
He feels a little pain.
Pájaro. Qué interesante.
The donation is about feels good. They donate the reality device.
Cangrejo. No te mandaron al espacio, hay otros niños que los mandan al espacio. 1, 2 y 3.
And this is our team of volunteers. They call it Alinen, and thanks to the alliance with them, we are improving. Here are the volunteers, while there are that how to fill out the forms, and here in the second picture with a little boy cheering him on. Other picture, so here one of the volunteers give to cell phone for the distraction or interview the parents to fill out the forms. And they also help us, the nurse, apply the topical anesthetic, and other one of our little ones walking around waiting for the turn to place the peripheral line. And all the children also using mobile and device, and the mother also collaborating with us. Thank you very much to Mike and the Jerry's and your team, because in the monthly meetings, they have us to support and tactics to improve the challenges we face every day. And despite all the problems and challenges, we have managed to carry out the project. Many parents feel that we do our best to improve their child's pain experience. Many parents, even in other areas such as chemotherapy or emergency room, are requested to use the topical anesthetic to reduce pain in their children. And that's a surprise because parents now know that there are steps to reduce their children's pain. And the alliance with the volunteer has helped us improve the lack of personnel and positive feedback from the staff implemented the project. Thank you very much.
Thank you very much, Dr. Cecilia. That was great. It's good to hear your story. And I think one of the strengths of our webinar sessions certainly has been the opportunity that we've had to hear so many different stories and experiences that are so different, but there are common threads throughout. And so thank you for sharing the experience you've had in Peru. We are inviting you to ask Dr. Cecilia any questions, to make any comments on your presentations. But let me start and ask you a little bit about your challenges. Because your slide on the challenges made me think of, many of challenges that are quite common in different places. I think your challenge around the political instability is a major challenge, I would imagine. But I really also think that the idea of collaboration and engaging nurses, volunteers, there's quite a broad consultation you seem to have. But I want to ask specifically, because I'm a nurse, so I want to ask specifically about nurses and some of the challenges. You talk about the nurse overload, the work overload, short-staffed. What are the kind of some of the how have you tackled some of those challenges with nurses, with nurses getting on board? I understand that if you are already overstretched, this might be perceived as extra work. The nurses might see this as something extra. So I want to know specifically about how you've addressed that with nurses, and how have you managed to gain their confidence. So how many of those that you initially strained are still with you, given the staff turnover?
Yeah, at the beginning, it was a very difficult challenge because the personnel, the nurses say that it's a lot of work and they have a lot of work with patients, and we introduce the comfort of the project. No, for the comfort promise is increase his work. But then when we talk with them and demonstrate that when use the comfort promise, use the powerful line, the time reduce. So they don't fight with the patients, so it's more easy for them. No? And this is one of the very, very important things that then the nurses apply the comfort promise, no? Because she really see that with these principles, she can reduce the time to put the peripheral line. No?
So it actually makes her job a little bit easier. So I guess, in English we say the proof is in the pudding. It is through the experience that maybe you win the nurse's confidence. That's really great. Dr. Ceci, we have a question from Anina Mayring, who wants to know, are your volunteers all trained nurses?
No. Our volunteers no are training nurses. It's only people that work a long time ago in the hospital, and they are important because they are not a health personnel. They are personnel for his house. No? So they feeling that the child never have suffered. Maybe now, okay, all the personnel know and are see a child suffering or the prick, no? But they don't say, oh, sorry, get used for that, no? So it's very important that not nurses. They are different persons. But we train it for the project, no? Train it them for project.
So your volunteers, they come from different backgrounds, you're saying.
Yes.
They might not have even a medical background.
No.
But the intention is they want to support children, and they don't want to see children suffer. So this is their way of helping. And do you train them at all? The volunteers?
Yes. We
Them.
train the method. Yes.
Okay. And what kind of training are they undergoing?
We train about the device, virtual device, and try to fill the data in the forms. And they put, for example, the anesthetic topic.
Okay. So a little bit of administrative, but they also help with some of the sort of like applying the EMLA or the topical anesthetic. All right. And what about engagement with the parents? In your little video, there was a parent I remember seeing, but are parents, how involved are parents?
Yeah, parents are very great about the project, so they are very involved. No, they work with us in that, no, because they don't want to see the child suffering. So the experience is that they are very happy about that.
Okay, good. We have a question from Martha, who is a child life specialist from Kenya, and she's impressed by distraction during the procedures that you showed. And so, what is the name of the gadget? She wants to know. And Pamela also wants to know, what devices are you using to distract the kids? So, if you can talk about the gadgets, the virtual reality gadgets that you used.
The virtual device. It's a mask. We have an organization that maybe I don't have a name. This is only a virtual mask that we received the donate for a person from Spain. And we not only use that, we use a lot of things, no, like toys, like for cell phones for the person the patient that is a teenager, for example. No? There's a difference. If it's like a box, no, and the patient have that I don't know, 5 years. Okay, we need to use that. No, or the person have 10 years. Okay, we use the virtual reality, for example. No?
So what you distract with is you're using age-appropriate devices.
Yes.
To distract. Do you use music at all?
We use music. Some the volunteers, for example, the volunteer for the Wednesday, she's a song, no? and use the guitar. Yes. But this is different for day, no? Each volunteer is for day. For example, for Monday is always the same, no? The same volunteer for so they have a different capacity, no? So Wednesday is with music.
Yes. So that's great. As a team, we all bring different components, and so therefore we're able to provide care that is culturally appropriate, what we're aiming to do, but is also pretty unique, because we are unique members of the team and we bring our unique strengths to the team. Nerman asks, she says, some children are afraid and cry before procedures, fear of parents with the load of work. How can the situation be controlled? It's an interesting question. What would you say to Nerman?
It's different. It's difficult in some case, but for example, in this special area, we create, for example, now we have a Barbie box, for the moving, so the children take a picture first to enter the room. In some case, you can see they drive a little car or a little motorcycle. no, in the room, in the same room. So this destroyed previous the procedures. No?
So it sounds like you need a lot of creativity.
Yes.
You need to think differently, and children are unique as well. So what might work with one child might not work with another child. But you know, there's been it's about finding what is right for your setting. I would imagine you using the resources within your setting as well, using support of the parents, of the volunteers. But I guess communication is key as well.
Yes.
You know, communication is really important, and communicating with the child, communicating with the family is really important to alleviate and to address some of the fears. Stanford says, great innovation. I've been encouraging parents to use their mobile Android phones with age-appropriate games or cartoons to distract them during procedures. Also really important. Yeah, that's great. I like the bit you said with age appropriate gamings, because you know not everything that the
Yes.
Android is going to give us is appropriate, and can probably even raise the anxiety levels more than and then alleviate it. Sorry, wrong button. Elvis says that it would be interesting to know the global statistics of how political changes are contributions or affecting the development of pediatric palliative care. That is an important consideration, I agree. And maybe, you know, there's so many right now. There are so many areas in the world that are being threatened politically, different parts of Africa, different parts of Europe, where there is an incredible amount of, in Asia as well, incredible amount of political instability. And we know that children and young people are the most vulnerable in those kind of settings. Maybe organizations like Pal Chase, Joan's on the call. Maybe Joan, if you have some global statistics, I don't have them, but if you'd like to address that, that would be great. Martha goes on to say that I believe preparation prior to procedures is key, absolutely, and it works well in the hospital. So yeah, it's really, really important that this group of children that are undergoing procedural pain, that their needs are managed, you know, that their needs are addressed, are acknowledged firstly, and then that we work together as healthcare workers, you know, whether we are doctors or nurses or social workers or volunteers to address this pain, because if we don't, as we know, it impacts on them later in life as well. I wonder, we're going to have to finish up in a few minutes, but I wonder if there are any other comments you'd like to make, Dr. Sisi?
Yeah, I forgot to say that when you use the topical anesthetic, we don't know where the nurse put the lines, so we use both of hands, no, for topical anesthetic, and then the nurse see where is where put the line, no? The peripheral line.
Sorry, I missed that. You said you do what so that the nurse could see?
We put the topical anesthetic in both hands.
Oh, okay.
So
okay.
then the nurse, see where is when put down, no? Maybe in the hand, right hand, or maybe in the other hand. So this is important.
Great, great. I also wanted to ask, you know, I saw your numbers rise from when you first started that, from 6 patients to over 100 patients now in 2023. And it wasn't clear whether you'd expanded that program to inpatients as yet, or were you seeing outpatients primarily?
Yes, at the first we do the program in inpatients, but we see that in the majority of the case, the patient have a center line, so they don't need to put other lines. So we review our other rooms, no, our other area for our hospital. So decide to begin the project in the procedures. Ambulatory is outpatient, no? And this is more useful because all day we need to put 15 or 20 peripheral lines. So this is the reason why do it now in this area.
Sure, thank you. All right, I wanted to see whether we could, as I said earlier, I think that might be a little bit tricky, but as I said earlier, all the presentations, so today's webinar will be available on the ICPCN website. Probably in the next few days, you'll be able to view it. And I know Dr. Mike wasn't able to show us the video, but we will set that up and hopefully you will be able to see the video that he was trying to show up with the song in Brazil. So hopefully you will see that. You can catch that on our YouTube channel. A comment from Joan to say that we see if children's palliative care is well integrated into health systems, it continues despite political changes. Sadly, so few countries have it well integrated, and it is not a priority. A wonderful example of continuing children's palliative care in a crisis is Ukraine, where despite the war is continuing to be provided, just an adapted form of palliative care. Thank you, Joan. Thank you for that. Okay, well, thank you so much, Dr. Cecilia, for sharing with us today. We will, Anina, we will certainly have contacts for both Dr. Cecilia and Dr. Mike at the bottom of their presentation, so you can catch that. I just as we close off, I just have a few little housekeeping things to say. Let's just go back to that one. Sorry, you might have noticed I'm not Julia Downing. I know there's a picture there that says I'm Julia Downing, but I really am not. Sorry, we just need to... Can you see my screen yet?
Yes.
Okay. Okay. Sorry, we've done that already, and you've heard from both presenters, and we've had our panel discussion. Just to say that please do complete the evaluation form at the end of the webinar, and remember that you qualify for a certificate if you've attended at least 2/3 of this session. I need to tell you about our next webinar, which will be held on the 19th of October. And in this webinar, we'll be hearing about children's hospice nurses and the management of emotional labor and professional integrity in long-term relationships with parents. We're delighted that Dr. Mandy Brimble from Cardiff University will be facilitating this session. So please save the date and look for our notifications and advertisements after the webinar. Another important date to save is Friday, the 13th of October. It is our Hats On campaign, which is now in its 10th year. This is an annual global awareness campaign that shines the spotlight on the estimated 21 million children and young people that need palliative care every year. So there's an urgent need, as we know, especially in low and middle income countries. And this number is projected to rise as the population continues to grow in low and middle income countries. So please consider supporting the campaign. Wear a hat, flood social media, donate to your local hospice or to ICPCN. Importantly, please register your event on the ICPCN page. So if this is a digital toolkit, and if you go to the website, you can download the toolkit and you can find out how to register your event on a global map. So please let us know what you will be doing this year in your community to raise awareness. And then if you are not a member, please do join ICPCN. Membership is free. And don't forget to check out our new website, explore resources on the site, and download our most recent impact report. This is the QRO for the website. Yes, and so finally, I would like to say thank you for being part of our discussions today and for all that you are doing for palliative care. And we look forward to seeing you next month. Once again, thank you to Dr. Mike in his absence and also to Dr. Cecilia for joining this session. It's been good to have you. That's it from me, and stay safe and be well. See you next month.
Thank you.
Bye-bye. Bye-bye. Thank you.
Bye-bye.